This is the OrthoSpin automatic adjusting strut, which is now compatible with the MaxFrame system. This is one of the first cases that we all did together. And I'll just go through the case quickly and give you my impressions. So we have a 43-year-old male. Here's a guy who has bilateral genu varus, and we performed bilateral simultaneous corrections of varus and some sagittal plane deformity. I'm not going to get too much into the measurements and all that, but what I want to show you is we used OrthoSpin on one side, manual struts on the other side. So this is one of these, what I call a randomized control trial of one, which can be pretty helpful because that same guy is judging both sides. So this is what it looks like immediately post-op. And this is the first case we did in the U.S., I should say in HSS. And the team from Israel came and we attached all the electronics at the bedside post-op. This typical MaxFrame software, and you can see that one's right side, one's left side, so that the actual mechanics, nuts and bolts of taking the X-ray, uploading it, mapping it out, that's the same whether or not you use the OrthoSpin struts. And then once you have the schedule, we'll give that to our technician or the OrthoSpin group, and they'll then upload that into the system, and then they'll then do the magic that divides these adjustments into multiple sessions. So in this patient, on the right side, he had OrthoSpin. We started post-op day 7. It was a 19-day schedule. We set it for a degree per day, and each strut was adjusted over 4 sessions. So normally you have to do an entire millimeter to get the struts to adjust. And when you do it manually, but when you do OrthoSpin, you can set it into multiple sessions. The first wave was basically mandated to be 4 sessions by the FDA approval. So we only did 4 sessions per day in each strut. So if a strut moved a millimeter in one day, it would move through 0.25 over 4 sessions. So much more gradual, slow rhythm, same rate, but different rhythm throughout the day. The manual struts started post-op day 7, 19-day schedule. Struts 1 and 2 adjusted in the morning, 3 and 4 in the afternoon, 5 and 6 at night, kind of the typical way we've been doing this. Here we are at the end of correction, and here's the frames at the end of correction. We use the usual method of intraoffice standing x-rays to look at mechanical axis, the slight overcorrection because he had a little bit of medial medial disease. And so at the end of distraction, we were changing the struts back to manual struts. That was part of the protocol at that time. And then, these heal well, so I can't say that one side healed faster than the other, but early conclusion was that the patient had no pain, no stress on the OrthoSpin side. So he didn't worry about that side. And, you looked at what Dr. Shu had to say, and not having the cognitive aspect of what we do can't be completely discounted. So the stress of knowing you have to adjust your strut and that, gee, strut 4 really hurts every time I adjust it, and just knowing all day long you got to do that adjustment and it's got to be a full millimeter. So there's a stress level that probably feeds into the pain pathway. And then there's also the physical jump of a whole millimeter at a time. Sometimes it's 2 millimeters, and we'll tell the patient, well, do half of strut 4 in the morning and half of strut 4 in the afternoon. It starts getting pretty complicated. And there's no great system that has an algorithm for if one strut moves 2 a day, another strut doesn't move at all. How do you split up this strut into 2 times? It's like, it's hard to explain this to people. And some of them get a little bit confused and it can be uncomfortable. So we were very happy about this automatic adjusting. People loved it. So I thought they'd say, God, this is so bulky, it's heavy, what is this thing? Everybody loved it. And you realize that people don't care that much if the frame's a little smaller or a little bigger, because it's still this big frame stuck on their leg. So they'd rather have the automatic adjustments. The problems at that time were having the Israeli surgeons fly out to New York to upload the program and do replans halfway through the program. So that was a pretty simple case. Smooth driving. There's a simple varus deformity. well, let's take this thing a little more off-road and see what else we could do with it. So my second case was pulling through a hypertrophic non-union of the tibia. Here's a patient, hypertrophic distal tibial non-union, history of infection. He had a free flap after a wound breakdown. Here he is 10 months post-injury. So how to treat this, but let's just focus on, okay, I treated it with an external fixator, tried to utilize the inherent biology, and there was no clinical signs of infection, negative labs and everything. So we kind of figured this was a burned out infection after all the hardware had been removed, and treated this with fibular osteotomy and then gradually pulling through the non-union. Fibular osteotomy. This is a video. Oh, it actually works. Amazing.
We're looking at the stability of the non-union.
And you can see how that is pretty stable.
His non-union's not moving much. Less than 5.
That's after fibular osteotomy with no hardware. So I graded that as a stiff non-union. So we could pull through it. There's the intraoperative mobility of the non-union. So I thought this was a good case for that. So, you know, we're pushing the frame now. What can these struts do? Let's be sure they're just as strong as the other struts. I added a foot ring just for a little more stability because we're talking about a small distal piece of bone, truthfully. No half hinge, just wires in that little piece of bone. And so immediate post-op, upload the x-rays, do the program through MaxFrame system, and then hand it over to OrthoSpin team. They upload the program and then gradual adjustments. This is what the device looks like. And this thing did great. It was able to pull right through this non-union. It was able to realign it to where I wanted it. I could have changed this, but actually the geometry of the bone dictated that was going to be the easiest way to align this. And so I accepted that alignment, not an issue with the frame. Patient consented to giving his photo. What was notable, this guy had no pain and took no opioids after he left the hospital. So pretty impressive. So pulling through a non-union, lots of wires, and this was only 4 adjustments a day. What if we did 10? What if we did 20 adjustments a day? Really broken into small adjustments. Again, Dr. Moore flew to the case. Dr. Moore flew to New York for replan. So there's a workflow problem, right? I use this for supramolar osteotomy with ankle distraction. So yeah, you can fit all these pieces in there and get it to work is the take-home message here. For gradual correction plus distraction. And that's kind of how it all fit together. Again, this guy had no pain and no opioids. He did get a pin infection. I was hoping maybe we won't even see pin infections because it's so gradual, the skin is happy, but he did get a pin infection. U osteotomy. So I've used this for U osteotomy. I've ended up using it around the foot a fair amount, as you can see. And same idea, like this can be pretty uncomfortable doing the distraction through a U osteotomy. Part of the limitation of the first generation was that the struts all came in one size, and if you needed a longer size, you could put an extender on it. But if you needed a shorter size, you were stuck. So your working length had to be a little further than you might normally use. U osteotomy went well. The guy's in a corrected position now. The Saltzman view shows that he has a well-aligned heel. Then we're just waiting for him to consolidate. Again, this guy had no pain, took no opioids. So, you know, I think there's a lot that goes into the formula of how much pain people are expected to have. I think this is more of the mechanical side of that. And with X-Fix, right, which is the most painful method we use to correct anything, yet this seems to be a good avenue for reducing pain. So what innovations have we come up with now? Well, these two guys. So OrthoSpin now has a support team in the US, and this is Chris, and he's mobile, and he supports the cases and actually does the uploading of the programs and speaks with the Israeli group every day and is very good at this. And then I have my own Diffuse Synthes rep who also can upload programs in a pinch. So no longer does OrthoSpin need to send an Israeli surgeon out here to upload programs. The future's bright. We've already done 7 cases at HSS with G1, and then we did our first G2 case this week. And this is easier workflow even. These struts are the exact same sizes as the normal struts for MaxFrame, and then you just clip these little motor battery packs in, and they're extremely light compared to the other system. It's only one battery pack.